following presentation is for informational purposes only. It should not be considered medical advice or is intended to take the place of consultation with a licensed medical practitioner. Imaging as we age, a radiology perspective. Presented to you by the Department of Radiology at Lovelace Westside Hospital. So a little bit about me. I'm actually the Director of Diagnostic Imaging at Lovelace Westside Hospital, and I have quite an extensive background in imaging. I graduated from radiology school back in 1989, back when we all rode dinosaurs to school. Actually, not quite that far back, but I have in my career worked in the Catholic County and for-profit healthcare systems, and started my career in 1989 until 2002 as a staff technologist, working in CT, CAT scan, which is commonly called, and also working in interventional radiology. And in my career, I've been very fortunate to had an extensive background working in lots of different areas. I've worked everything from general radiology all the way up to working with neurosurgeons and doing brain biopsies. So I've had a pretty extensive background in doing lots of different things in the radiology field, and I've been very fortunate in my career to do so. I was the Administrative Director of Radiology and Cardiopulmonary at Eastern New Mexico Medical Center when I made the dubious choice of moving into leadership from being a clinical person to moving into management in 2002. And I held that role from 2002 until July of 2017. In 2017, I took a leap of faith, went to work for Lovelace, moved to Albuquerque, and July of 2017, I left Eastern. I came to work for Lovelace, moved here, and I've never looked back since. I really enjoy the Albuquerque area, and I really enjoy working for Lovelace. Additionally, just to pad the slide a little bit, some of my additional education that I've had in training, and I've actually trained at Oak Ridge National Labs in Oak Ridge, Tennessee, in Radiation Emergency Incident Command. And I've also trained at the University of Texas San Antonio Medical Health Science Center in advanced radiation safety training. And lots of other things, but that's just kind of a real synopsis of my career and background. I am a registered radiologic technologist with the American Registry of Radiologic Technologists in both radiology and computed tomography. And I'm also a licensed radiologic technologist with the state of New Mexico. And probably my most proud achievement is the fact that I am a husband, a father, and a grandfather. And I have been married to my beautiful wife for 27 years. We are a combined family. We have 7 children. And she'll kill me, but I have at least 12 grandchildren. I think probably more than that. I'd have to count them, to be honest with you. But quite a few. This is my beautiful wife with me. She's the one with the long hair, by the way, in case you were curious. And that was me as a kid. So I actually read on the internet that if you have a beautiful wife and you're a cute kid, the people should pay attention to what you say. So I thought I should prove both of those things. So there you go. Well, thank you for being part of today's presentation. And we just want to kind of move on and talk about what we're here for today. And we're talking about imaging as we age, a radiology perspective, and how imaging affects you as you get older, what the dynamics are, and how that may or may not be different from other types of imaging, and other age groups, younger people, so on and so forth. Well, George Bernard Shaw said, "We don't stop playing because we grow old. We grow old because we stop playing." And to an extent, that's absolutely true. As we get older, we get more sedentary. We tend to be less active. We tend to do less things, and it has a profound effect on us. It hurts more to get out of bed in the morning, and we just don't want to do stuff. So that actually has a downstream effect. We can't eat like we did when we were 20, although we like to think we can. And all these things have a negative impact on our long-term health care. And old habits are hard to break, and old dogs are resistant to new tricks. We all know that. So some of the things we want to talk about is, how healthcare affects you as you get older. What are the things that you should look for specifically in imaging, and what can you expect as far as testing and so forth, and what kinds of things, disease processes are most prevalent in older Americans and older people in general. And as the cartoon says at the bottom here, my bones are getting softer, but my arteries are getting harder, so it balances out. And we like to think those things are true, but they are not, unfortunately. Soft bones and hard arteries are hardly anything to brag about, but they're all things that we ultimately have to deal with as we age. Well, imaging is part of your health. One of the most important tools we have for evaluation of patients is diagnostic imaging. It's non-invasive by and large. We do invasive studies in imaging where we do the poking needles and putting things in you, the stuff that nobody likes to think about when they go to the doctor or the hospital. But a lot of it's just benign pictures. Now, we do have to be relatively careful in radiology because, at the end of the day, we do use radiation, X-ray for a lot of the things that we do, not exclusively. There are things like MRI and ultrasound that do not use ionizing radiation. But it is a reality of modern healthcare. But with modern equipment, the doses are very minimal, and the likelihood of having any long-term effects on somebody, an older person in particular, is pretty negligible. We're very careful with much younger people, children, adolescents, childbearing age women, and so forth. We always want to be cautious about them and what we're doing. But for the most part, as we get older, we're a little bit more, I wouldn't say bulletproof, we're just less likely for it to have any long-term effect on us that's going to have any meaning. For older patients in particular, we not only have exams that are geared more toward older age groups, but we often have specific anatomy variants that we expect to see. So, in other words, the internal anatomy of a person that's 70 is going to be much different than the internal anatomy from a density perspective and an appearance perspective than a person that's 20. The stomach's still there, the liver's still there. Hopefully, all the stuff is still there, and it's generally in the same spot it was in the beginning. But it does change in appearance somewhat as we get older. Imaging exams that can be done at any age. Imaging exams can be done at any age, but as an example, exams that are more prevalent for older patients, a good example is mammography and bone density. And we're going to talk a little bit about both of those. Anatomic variance can happen in any age group. You don't have to be an older person to have unusual internal anatomy. It can happen for lots of different reasons. We call that a congenital abnormality. Or it could be just what is also considered a normal variant. So not everything is bad just because it's different. But as we get older, we do expect to see certain changes. We do look at the density of tissue. You can determine that. So a 25-year-old football player is going to be much denser than a 65-year-old marathon runner. It's just the nature of the business and how your body matures and grows and changes. Bone density and the appearance of brain structure are just a few of the other things that we can look at, and we can know that we're looking at an older person because of those changes. Or in some rare circumstances, we may be looking at somebody that's younger that has some other severe degenerative process. But typically, those are the things that we look for to know that that's actually somebody that's an older patient. Mammography, breast ultrasound, and breast MRI. And these are breast care specialties, and one of the misconceptions is that all breast care is female related. That as a woman or a female patient, that you're, the only game in town. This is strictly a women's issue, and that's not necessarily true. Men do develop breast cancer. That's a little known fact and kind of a scary fact for some men. But it is obviously more prevalent in women, and for that reason, a lot of our tests revolve around women's health care. And so one of the most common things that we do is mammography. Now, a lot of times people will ask, why 50? Why not 40? Why not 30? Why not 20? What about the mammograms at a younger age? Well, it's simply put, there's a lot of dynamics involved with that question. It's not a simple answer. There's a one sentence, this is why we do the way we do it. The reality of it is there's a lot of things that play into that, but quite simply, one of the most basic things that we have to take into consideration is breast density. A 20-year-old woman just naturally has denser breast tissue than a 50-year-old woman. the denser the breast, when we do an image of the breast, the way that mammography works, these structures become less defined. So it's kind of harder to see something in a 20-year-old breast than it is in a 50-year-old breast. Not to say that a 20-year-old woman cannot develop breast cancer. They absolutely can. I have absolutely seen it. And it's very frightening and scary for anybody, but especially for a much younger person. There are other things that we can use for younger patients. Typically, physical exam is probably one of the most common, and ultrasound can be an alternative, although we do not like to use ultrasound except for very certain circumstances as a primary screening tool, for the very fact that there are other things that that play into that, and it can give what we consider a sense of false security. Ultrasound in and of itself is not typically used as a screening tool in the vast majority of institutions, and it is easy to miss things sometimes. It's more of a targeted tool. You're looking for something specific to define, is it or is it not something. If you look at the pictures that are here on the screen, you'll see a traditional mammogram versus a 3D mammogram. Now, we'll point out that even the traditional mammogram, otherwise known as a 2D, is actually very good compared to what we used to use. This is all digital technology nowadays, and compared to the old film screen systems that we used to use, we actually had a piece of film, we put it, we had to develop it just like you do old 35 millimeter film. We're light years ahead of that now. So even though we now have 3D technology, the digital 2D technology is just infinitely superior to what we used to have. But looking at these two pictures to show you comparison right there, you're actually looking at the same breast with a 2D image and a 3D image. The 2D image actually represents, you can see this little circle there, it actually shows exactly where the mass is. And it is not very obvious for a radiologist to look at that. You could armchair quarterback that and say, oh, it's right there, but if that circle wasn't there, you wouldn't pick it out very easily. If you look at the 3D, that kind of mushed look right there in the middle of the circle, that is a clear indication that there is something there that's not right, that it doesn't belong. And of course, this is the same breast, and that's why the 3D technology we use nowadays is so superior to what we used to have, even with the 2D technology. So our technology increases in leaps and bounds. The picture right below both of those is actually a ultrasound of the breast of this same area on the same patient. So you have the 2D, the 3D, and then you actually have the breast ultrasound. So that's what we're doing with the ultrasound, as we go in and say, okay, it's there. What the heck is it? Is it a dense? Is it a cystic mass? Is it a fluid-filled mass? What is it? So ultrasound actually solves that for us. We can go in and we can determine that what it is made of by and large. Now, at some point, the next step is, and not always is it linear, but MRI is a very good choice too. Now, MRI is not a great screening tool because A, it's very expensive, B, it's a complex procedure. It is not a simple procedure. A screening mammogram you can go in and get done in 15 minutes. With a MRI in 15 minutes, you're barely getting the machine running. So it is not a simple procedure, and they are not simple for the patient either because of the positions that they have to be in. So typically, we're going to that next level of problem solving with an MRI. And the image that you see there of the two breasts, that's actually what the patient would be prone, laying on their stomach, and their breasts would either be dangling through what we call a breast coil, or they would be in some kind of holder. And we do inject dye into the patient for these kind of exams, and we look for the vascularity inside the breast and how, if anything, enhances with the contrast material we use. It's a gadolinium-based substance, which is a heavy metal, and it is the same substance that we use for lots of other types of MRIs as well. To go back to what I was mentioning before about men, you can actually see there, that is not a lady with a very prodigiously hairy chest. That is actually a man getting a mammogram. And this is for demonstration purposes. And as you can see, this young lady is actually in the military. That's actually Air Force camouflage, by the way, in case you were curious. And she's doing this for demonstration purposes, but this should show you that men do get mammograms. And predominantly they're older men, but young men can get them too. So, and just like a young woman that develops breast cancer, it's a very horrifying experience for any age, but especially for a younger person. Same thing for a young man, because men typically would be in a state of denial about something like that. And to go to the next slide, actually we know that male breast cancer actually goes undiagnosed for quite a while. So risk factors for cancer are many, but they include your age, your genetics. If you have a long family history of breast cancer, your mom had it, your aunt had it, your sisters had it, and I've actually seen that in family trees where, almost every adult female in a family has had breast cancer. I've actually seen the mom, her sisters, and all of her daughters, all under the age of 30, all develop breast cancer. So that is rare. It is not a common thing to be that prolific, but it can occur. So genetics play a very strong role in, that type of equation. Those things you have to think about. Body habitus. A healthier person is much less, statistically less likely to develop a cancer than a person that may have other health issues or may have, body issues, things of that nature. And that's just, the way it works. It doesn't mean you're bulletproof and you can't get it. It just means that your likelihood diminishes. Activity level. Somebody that's very active and very, takes care of themselves, things like that. Again, your incidence of cancer, likelihood of developing a cancer diminishes. It doesn't go away, but it does diminish. Alcohol use, excessive alcohol use can actually precipitate, cancer starting in the body. Alcohol does destroy certain structures in your body, and it can cause long-term ramifications. Reproductive history, can play a role in that. And, but you got to remember, it doesn't matter. If you meet none of these criteria, you're the perfect age, you have great genes, you're, could beat up Arnold Schwarzenegger and outrun the Flash, you could still get cancer. So it's not a matter of being the perfect person and not getting it, man or woman. It can happen to anybody is the thing you have to know. And you have to always be aware of your body. Those are the reasons why we have healthcare, to assist you in maintaining your health. A good example of two well-known women that actually suffered from breast cancer is Angelina Jolie. She had all the genetic markers for a high incidence of breast cancer. In fact, it was very likely that she would develop breast cancer. And so she had prophylactically removed both of her breasts, which some women elect to do. And some women that do develop breast cancer as they get older, and they make that decision. They say, you know what? I don't want to go through the whole rigmarole of taking out a lump. If you think that my risk is great, I would rather just not even have the breasts anymore. Let's just do away with them. And some women do make that choice. Julia Dreyfus, tragically, she did develop breast cancer. It's a pretty horrific story. I believe her father died, her mom died of cancer, and then her sister died in a car wreck or something like that in the midst of her going through her breast cancer trials. And she ultimately did have bilateral mastectomies as well. The breast cancers are most commonly found in women over the age of 50. It's when they do occur predominantly, not exclusively. And some will get breast cancer even without any other risk factors. In other words, it goes back to what I mentioned earlier. You could have the perfect lifestyle. You could have the perfect genes. You could be the healthiest person in the world and still get it. And unfortunately, cancer plays no favorites. It doesn't care who you voted for. It doesn't care where you go to church. It doesn't care what you believe. It doesn't care how tall or short you are. It doesn't care about your skin color. It doesn't care about anything. It is a very destructive force, and it comes in many forms, and none of them are pleasant. So going back to what we discussed about male breast cancer, male breast cancer typically shows up in men 60 and older. Now, again, that's not an exclusive statement, but that's typically where we do start to see that become an issue. Now, the mortality rate is higher because the healthcare for men is there, but that's not something a lot of men look for. They're not thinking breast cancer, thinking, man, that's a funny thing in my armpit, or, what's this knot right here? And they just ignore it and go out to the wood shop or go hunting or go play golf or whatever. And 3 months later, they're like, honey, what is this thing? What do you think? And they come in to see us, or they've seen their provider, and we're trying to do a workup on them about something that's already progressing very rapidly. Male breast cancer tends to grow quicker than female breast cancer. It just kind of gets out of control and takes, really gets very aggressive. So seeing, as you can see in the picture of the gentleman there, it's not uncommon to see men that have had breast surgery and had their pectoral muscle removed because of that. And as we get older, we got less muscle and, you know, more flab. It's just, you know, again, it's a nature thing. But that does happen. I've actually seen, this gentleman here had very good surgery, and I'm hoping he had a very good outcome. I've actually seen a male breast cancer survivor that literally looked like somebody had taken a giant ice cream scoop and scooped out a chunk of his chest, is how deep they had to go into him. He had pretty progressed disease by the time anybody acknowledged it was there. And unfortunately, you know, at that time, they felt comfortable that they had gotten all of it, but you never really know. And the extent of his surgery is pretty devastating. I'm sure it had a pretty profound impact on his life. You don't take pieces of your body away, especially in large quantities, that it does not have some kind of downstream effect on you no matter what. The next test that's typically considered a screening test is bone density, or DEXA. And DEXA is used to determine the density of your bones. We look for osteoporosis predominantly. And again, this is kind of geared more toward women, but men get bone densities too, and there's reasons why. As a man, if you've had to take a lot of different medications, if you've had to take steroids, you've had extensive steroid use in your life, whether it was the steroids at the gym, which I hope you don't do, or taking prednisone, things like that for health reasons, stuff like that, that can cause destruction to your bones. So there's reasons why a man would get a bone density as well, or it could be genetic abnormalities, things like that. And so men would come in and get a bone density. A bone density is a very benign test. It doesn't take very long to do. It's very simple to get done. Years ago, the FDA had considered making it a screening test where you could self-refer like you can for screening mammography. Unfortunately, that never really got any traction, and you do have to have a doctor's order. And going back to what we discussed about mammography, for screening, you do not have to have a go back a slide here if I can. No, let me. You do not have to have an order for a screening mammogram. You can self-refer. We do ask in a self-referral situation that you do provide us, or any institution of your choice, I should say, with a provider we can send the report to. Because at the end of the day, even if you self-refer, we want that report to go to a practitioner. We want it to go to your doctor, your nurse practitioner, your PA, whatever. So number one, they know you're okay. Or number two, if we find something, we have to have somebody to get in contact with. So it's much simpler to know that on the front end. Men typically, when we don't really do per se a screening mammogram on men. By the time we're doing mammography on men, it falls in the realm of what's called diagnostic mammography, and that's a little bit different animal, and that does require a doctor's order. And at that point, there is practitioners involved in your care at that point forward, because you're going to be getting a lot more testing than just the mammogram done. And the same for women. If we find something in your mammogram, there will be a provider involved, because you will have to have more testing done beyond just the screening stuff. Going back to the bone density, there's really no additional stuff that we typically have to do for it, like a diagnostic mammogram. For a bone density test, you come in, you get the test, we tell you what your bone density is, and then your provider makes a decision if you have to have maybe some kind of medication. There are some IV meds you can be given to enhance bone density. They could recommend vitamin D. There are calcium. There's all kinds of things that they could recommend for you to do to increase your bone mass, or care you need to take. Be cautious about it. No more diving off the high dive. No more water polo. No more skydiving, whatever things you need to do to protect yourself. There's things that they will recommend to you. As the slide indicates, the bone density identifies decreases in bone density. We look at the hip specifically in the spine, but we also look at like the wrist and so forth. We want to determine your risk for fracture, so we can warn you like, hey, you know what, your hip looks pretty weak. You might want to be careful about that when you decide to go play basketball or whatever. We confirm osteoporosis, like, oops, you actually do have it, and that's a report that goes to your doctor. Excuse me again. And we do monitor osteoporosis treatment. So if you're getting a treatment regimen, your senior provider They are giving you medications. They are treating you, whatever that may be. And they will send you back periodically for us to do updates on you to see how you're doing. Again, the risk factors are the same. You'll see this over and over again. Doesn't matter hardly what we're talking about. Gender plays a role. Absolutely it does. Women are more likely to be osteoporotic than men. That's just a fact of life. Family history. If it runs in your family, then there's a very strong likelihood it can happen to you. Bone structure and weight. You may have had issues as a child. There's all type of disease processes can be destructive to the bone as children, and you could have been a twin, and you were the one that developed some kind of congenital issues and so forth. There are all different types of criteria that can fall into that. Ethnicity does play a role. People of Northern European descent and people of Asian descent, women are more likely to be osteoporotic or to have these types of problems than other ethnicities or people from other parts of Europe, South America, Africa, Asia, and so forth. Well, Asian women, again, I'm sorry. But that does play a role in it. Again, certain diseases could be precipitous to that occurring. Medications, again, the steroids can be very destructive to your bones if they're taken in a way they should not be taken, or if they're taken for super long periods of time. And there may be reasons why you have to take steroids. But that's why you would go back for follow-up care with your doctor, and they would monitor that and see how you're doing. Smoking, always bad. If you smoke, stop. It's destructive to lots of things, not just your lungs, and it can cause a lot of long-term health risks. And if you're one of the lucky people that's smoked and quit, good for you. If you've never smoked, even better. If you are smoking, it's never too late to stop. So something you want to think about. And again, alcohol abuse. Having a glass of wine, having a beer every now and then, having a drink when you go out is not an issue. Don't overdo it. But if it's an abuse issue, if you're constantly, if you're putting away a 12-pack a night, if you're drinking a bottle of wine every day, that kind of stuff, that's abusive, and it's going to destroy your liver, but it also has a lot of other implications to your body, not just that. So things you want to think about. Mammography and bone density are typically considered proactive or screening imaging for the screening mammogram. Now again, if we do find something in a mammogram, or if you fall into a criteria of a man having a mammogram, it's going to fall into what we call diagnostic, and that's a different level of care. That's a different type of, it's the same exam, but we do extra stuff. And again, at that point, you're actually in the care of providers. You're being taken care of by your either your mid-level or your doctor, and a radiologist is overseeing your care at the hospital when you're going in for these kinds of procedures. They're reviewing your studies and making recommendations on what that they see. Excuse me. But there's other things in how imaging affects your body as we get older. So now, one of the things talking about osteoporotic bone, we can look at this, and there's actually two pelvises right here, and the pelvis on the left is actually normal bone. And I don't know how well you'll be able to see this, but if you look down, especially at the hip, the outer area of the hip, down into the lower left-hand corner, that kind of bump that sticks out there away from the pelvis on the far edge of the hip, that's called the greater trochanter. And if you look down into the bone there, if you look real closely, you can actually see some little wavy lines. Those are called trabecular lines in the bone. And because this is a younger person, that's normal. You like to see that. That means it's healthy bone. In a younger person, they're very obvious. You can see them really, really well. On the right-hand side, this is actually an older person that actually has a hip fracture. That's what the little arrow was pointing at. They actually have a crack in their hip at the surgical head right there of the hip. But if you go look for those trabecular lines in the bone right there in the hip regions, you don't see them as well. And that's because this person is osteoporotic. They're losing bone density. So those structures that we would see in a younger person are less apparent, less obvious, and that's because the bone is losing density. Now, the trabecular lines are still there, more or less. There's not really a smoothing of the bone per se. It's just because the bone itself is losing mineral density, they become less and less obvious. And eventually over time, you can get what's called a pathologic fracture if you have enough degradation of the bone to where your hip can just break. Other bones can just break. It doesn't require, falling off a curb or, falling off your porch or anything else. You can just be standing there and your hip will break. And that can actually happen as we get older, and there is a loss of that bone structure. So those are things that you want to be taken into consideration. Another reason why it's good to consult with your provider, to find out the things you should be doing. How can I be proactive? What can I do to make sure this does not happen to me? Nobody wants to have a broken hip, trust me. It's not a fun experience. It's miserable for the patient. And when we were actually trying to take care of you in the hospital, especially when we're doing imaging, I don't want to say it's a brutal process, but it's not pleasant. We have to get the pictures to determine the extent of the fracture, if it exists, which a lot of times we can tell by looking at the presentation of the patient. But we have to confirm it's existent because the orthopedic surgeons are going to be doing the surgery and need to see certain things. And it's just a tough thing. It's tough all the way around. So you want to be careful and protect yourself as much as you can. These are some more examples of a normal bone versus osteoporotic bone. This is a spine, actually. The spine on the left is actually a young, healthy spine. The image that you're not really going to see the director lines in this because it's the way we do the image, this particular one. But if you look over here on the right-hand side, this is actually older bone. The first image on the right, kind of in the middle, is actually an x-ray. So the analogy would be the one on the left, and this is an older person. And you can see the bone's just a little bit more transparent. It's what it boils down to. And if you look at the little boxes, those are vertebral bodies on the left-hand image. Those are the vertebral bodies. That's what those little boxes are. If you look at those same little boxes on the other image, you can see some of them are kind of smushed down. And that's bordering on what's called compression fractures. A lot of reasons why that can happen. Young people can get it too. Car wrecks. If you're a paratrooper, you might get a compression fracture. Cowboy getting bucked off of horses, that kind of stuff can happen to people. But it can just happen too. Again, it goes to the age. Bone metastasis can actually cause these kinds of things to occur where the bone degrades and they will compress and can be very, very painful. Looking over to the image to the far right, that's actually a CT scan, and it's reconstructed in what's called a bone window. And the reason we do that is just to get a better detailed image of the spine. And you can see there with a little greater clarity exactly, what that, the bones look deformed. The vertebral bodies do look deformed. And that's just age related. And as we get older, we do see age-related deformity. It happens. It's just the way it goes. But there are times when you can see, things are significantly wrong that are beyond what they normally would look like as far as just bone degradation. And those are the things we look for as well. Is something else going on? Is something else happening? There's a rabbit holes we get going down sometimes. So we look for this, but we see this, and we continue to look until we see what the root cause is. Common example I give patients all the time is, we see it all the time with upper extremity pain. Think, well, my arm hurts really, really bad. It's killing me. Fix my arm. Well, it's got nothing to do with your arm. It's actually your cervical spine, and you're getting nerve pain going down your arm. But conversely, you can get that going down your legs too. It's not really your leg that's hurting. It's actually your spine, your lower spine, that's causing the problem. So those are the things we look for, and we try to determine what exactly is going on with the patient. What can we do to try to make it better? What can we do to give the images to the providers to help them make a decision about what next steps are, so they can consult with you and say, hey, this is what we see, this is what we think, this is what we want to do. What do you want us to do? Always your choice. We can only recommend. We can't make you do anything. And it's up to you, and you have to make those decisions. And that's why I always tell patients, you want to be an informed consumer. You have the right to vote with your feet. You can go anywhere you want to. So you want to make the best decision that you can. And if you don't like what we say, you can go to the other place and get something done and see what they say. And you can compare notes. So that's part of your liberty as a patient that you need to be aware of, that those are the things, the opportunities that you have to empower yourself for your own health care. One of the things I tell patients all the time too is take notes, write it down. What just seems very apparent to you now, like, oh, I'll never forget what they said, that's important. A month from now, you're not like, what did that guy tell me? So, write stuff down when you go to your providers, write questions down so you don't forget, things like that. Very, very important. Sometimes you as the patient are our best source of information, believe it or not. Well, some other examples we have, and I can show you of as imaging as we age, is CT scans. And we have 3 CT scans here side by side. We have a pediatric normal brain. We have an adult normal brain. This would be a middle-aged person. And geriatric normal. You see a little asterisk right there. There's always an asterisk, just like Pete Rose, you'll have an asterisk next to his name for, gambling or, any of the guys that did the steroids that got the home runs and they took too many. But anyway, the reason this is asterisk is not for those reasons, but because that is a normal brain, quote unquote, but it is not always what a normal brain would look for that age of person. It may look infinitely better. A normal person, if that was, say, a 78-year-old brain, you may see a scan on another 78-year-old person, and it looks different, but much closer to the one in the middle. That person, just for genetics or whatever, tends to have a better brain over a long period of time. There's less smoothing, there's less destructive processes, so forth. But again, if we did this image on the right-hand side on a 70-year-old person, that would not necessarily be considered abnormal. It would be considered normal aging is what it would boil down to. The radiologist would comment on the changes that they see. The enlarging of the ventricles, which is where the cerebral spinal fluid is created. The structures that are very smooth on the middle and the child are now like kind of edged and jagged and so forth. So that would not necessarily be an abnormal brain, but that could definitely be just normal aging process. But again, you could start seeing changes in a brain like that. You could start seeing small changes because of small strokes and so forth. But technically, that would not be considered abnormal. That would be considered normal with an asterisk next to it. Next, we have an MRI of the brain. We have pediatric normal, and we have adult normal. And then we have a geriatric normal. Now, this is MRI. So you can see again, and I'll real quickly do a little education on CT versus MRI. A lot of people think MRI is better because it's newer technology. Actually, it's not. The math for MRI existed before it did CT. They just did not have the technology to develop MRI, but the math is actually really old. CT came about really in the 70s. You can thank the Beatles for that. It was EMI Thorne, actually the Beatles record label, that helped develop the first head CT scanners, believe it or not. And only head CT scanners were available in the 70s going into the 80s. We started having the full body scanners. And MRI followed on the heels of that. Now, the reason that MRI images a lot of times look like a CT image is a CT image is actually a real image. It's actually taken by shooting energy through your body, and that energy hits an image receptor, and we can make a picture. We make a picture out of it, just like taking a regular X-ray. It's a little bit more detailed than that, but fundamentally that's how it works. A MRI is made up, it's an image created out of math, is what it boils down to. They had to make it look like something, so they used CT images as their standard. We already know what it's going to look like in CT. We're doing the same body part. Let's make it look like this. MRI is very complex. I won't bore you with the details of it, but it's the magnetic field. It involves radio waves. It involves banging your atoms around is what it boils down to. So, and we can make a picture out of that. And again, that's why this MRI images look kind of like CT images, because they just use the CTs as the benchmark, so you know what you're looking at. The pediatric and the adult normal are both what we would typically see. The geriatric normal is there again, asterisk. A geriatric may not necessarily be that. It may be closer to the adult normal. But if we see this image or this type of image on an older person, we would not consider it abnormal. What we can say is that this is what we call the grumpy old man scan. So that tells you it's a geriatric, because you can see it's got a frowny face on it. Not really, I'm just kidding. It just so happens it has that appearance, but it has nothing to do with it being a grumpy old guy. So I'm the grumpy old guy. So moving along, we actually have examples of a grossly abnormal CT scan and MRI. CT of the stroke, CT stroke on the left-hand side. One of the things we do in the beginning, if we're concerned about a stroke, is we do a CAT scan. Now, we're not actually looking for the stroke with a CAT scan. That's a misconception a lot of people have. They think the CT sees the CAT scan. It does not. We're actually looking for blood. Early stage hemorrhage and stroke have the same symptoms in the beginning. So you could be hemorrhaging or you could have a stroke. Well, the treatment for stroke is to give you anticoagulants. That's why they tell you if you're having a stroke, take aspirin, that stuff we would give a patient. There's different types of medications we would give to anticoagulate the blood to help mitigate the damage that's being caused by the stroke. So we're looking for blood is what we're actually looking for on the CT scan. If there's no blood, that tells the provider, then I can move forward with giving anticoagulants to the patient. And then ultimately over time, after a few days, you can actually scan a stroke and you can see the stroke or the destructive. We call it ischemic exchanges in the brain. You can actually see the destructive process of the stroke. This is pretty dramatic. That is a pretty dramatic stroke that you're looking at. They sometimes are not that bad. Sometimes they might be a small stroke. I'm sure you've heard that term. But this is a pretty large stroke. It's actually caused what we call a midline shift. It's put so much pressure on the brain, it's actually causing the midline, where the two halves of the brain come together, to shift over to one side. And that is a pretty dramatic, that's a life-altering event right there. So on the right-hand side, we see MRI stroke. And actually this is less pronounced, no less of a concern, obviously. But you can see they have two different appearances. The one has the kind of grayish, dark black appearance. The other one has the white appearance. And that's just the difference of how the two systems work as far as imaging goes. We're going to look at a side-by-side comparison of CT and MRI scans. And these are more of adult brains, middle-aged adult brains here. These are not going to be necessarily geriatric in nature. And just kind of give you a side-by-side comparison of what a CT and MRI do look like. The normal brain on the left, you can see it marked as such. The image on the left-hand side is actually MRI, and the image on the right-hand side underneath the normal brain, that's actually the CAT scan. That's in the same, we call it the same plane or the same level, the same slice is where that is located. So that kind of gives you an overview of what that looks like compared one to the other. Structures you can see, of course, those are the eyeballs, and you can actually see on the MRI the optic nerve coming back. You can actually see optic nerve on a CAT scan as well, but you're just seeing from it comes back for the eyeballs going back into the brain. You don't really see anything other than that, whereas the MRI is obviously a little bit more detailed looking, those kinds of things. We can do specific studies to look at that type of anatomy. Going on the right-hand side, this is for MS, brain for multiple sclerosis. And these are typically going to be not geriatric patients. These are going to be much younger patients. 20 to 50 is where MS typically manifests. And you can see on the CAT scan, you don't really see the MS, but on the MRI, which is right next to it, you can see those little dense points right there. And those are actually called MS plaques, and those are things that we do look for in MRI to determine if a patient does have MS or not. The difference between, and again, going back to what I was saying before about one better than the other, really neither is better than the other as far as CT and MRI. They both play different roles in your healthcare. CT is absolutely faster than MRI. A really long CT scan nowadays is 10 times faster than a quick MRI is what it boils down to. CT is infinitely faster, and the way that we do the imaging, the way we acquire the imaging, the processing of the images, so on and so forth, is just infinitely faster. MRIs are much slower by nature. MRIs are also totally unforgiving of motion. They do have software and stuff that you can have on your system to help mitigate that, but on older MRIs, you could actually see a patient moving their eyes back and forth with their eyes closed if we were doing an MRI of the brain. We do have software nowadays that kind of gets rid of that, but it still can occur, and motion is still the enemy of MRI, and the length of time needed to do a lot of studies, and it requires a long time laying inside the machine to get just a couple of simple things done, whereas with the CAT scan, you can have multiple exams done in a short period of time. Again, the risk and benefit is CAT scan is radiation. We try to be careful about that. We don't want to cause a problem. Radiation is not good for you. It is dangerous. There is no safe dose of radiation. Doesn't matter what you may have ever heard. There's no safe radiation. It's all bad for you. If you can get cancer from mowing your yard on a sunny day, you can definitely get it from it blasting radiation through your body with enough force to make an imprint of your body on something else. So those are realities that we have to deal with, and we're very cautious about how we do certain things, and why our machines nowadays are much more efficient than they used to be. The amount of radiation we use for imaging nowadays, under most circumstances, some of the older machines would probably be able to acquire a decent image from stuff that was developed back in the 70s and 80s. And nowadays it just takes much less radiation to make those pictures, but it is still radiation. MRI is different. It doesn't require the radiation, obviously. It's a magnetic field, but again, magnetic field brings its own dangers to the situation. Aneurysm clips, pacemakers, things like that. We have to be very careful about those types of things. Moving down to the lower two images, this is actually a bleed. This is the same patient in the same area, and you can see the presentation of the bleed inside the brain. That little white looks like a caterpillar thing in there. That is an intracranial hemorrhage, and you can actually see the same hemorrhage over there on the right hand side, or an analogy to it. It's not the exact same one, but you can see the same area and everything else. That kind of gives you a visualization of what what they look like compared one to the other when we're looking at the same thing. So let's talk about digestive tract imaging. Well, as we get older, one area of vulnerability is your digestive tract. You get GERD, you got to have your colonoscopy. You can't eat hot sauce at 11 o'clock at night anymore. Last time you ate tacos, it almost killed you. I mean, as we get older, things change. So that's just one of the things, again, we're not 20 anymore. You have to remember that. Things to remember for your GI health: you want to stay hydrated, absolutely watch what you eat. Fiber and more fiber. You can't overdo that very much. If you're having regular bowel movements, you're less likely to develop problems, especially colon cancer, things like that. Be active, reduce stress. Good luck, I like to tell you on that one. Eat lots of healthy foods, and that's a problem. The healthier you eat, the more expensive it is. And some people have fixed budgets. They cannot afford to go out and just shop at Sprouts or whatever. They have to buy whatever's on sale at Walmart. So that can be problematic, but it is something to be aware of. So be as healthy as you can. I can tell you, for myself, I've developed a little bit of high blood pressure, and sodium is my enemy. And I've learned quickly that it's almost impossible to get sodium-free anything. So we've always prepared a lot of fresh food in my home, but we do occasionally like to go out or just open up a can of soup, and not anymore. It's really changed how we eat around here, and my wife's a good sport, and she tries to help me out as much as she can. So, and talk to your healthcare provider. You always want to have them included in this conversation. You don't want to trust the internet. If your healthcare provider is WebMD, you're doing yourself a disservice. I can tell you that right now. You want to talk to your provider, discuss things with them, and again, write things down. The providers are very busy, and sometimes you only have a limited amount of time to talk to them, and you want to be sure that all your questions get answered. And so definitely write stuff down and talk to them and get their opinion and see what they think about things. So we're going to look at digestive tract imaging. Upper GI is one of the most common studies that we do. It's where you actually swallow the barium. And it's not uncommon to swallow different thicknesses of barium or to swallow other things in addition to barium. But fundamentally, we're looking to see how things flow from your mouth through your esophagus, through your nasal pharynx, where everything hooks up in the back here, and how it goes down into your stomach. And we know what looks normal and what does not. And if you're having a lot of reflux, if you're having things like, man, things don't go down right, it feels like everything's stuck in my throat, upper GI is a pretty common test to have done. Another thing is a motility study called a small bowel follow-through, which is the image on the right-hand side, and that's all barium inside of a person's small intestines, which you have a lot of. And what we're basically looking for is how quickly things transit through the small intestine. There's an amount of time which is considered normal. So if we do a small bowel follow-through on you, and we're still taking pictures of you the next day, which does happen, that's a problem. There's actually something wrong. Your motility, something's messed up, and that's the reason we do those types of tests. Now, one of the things I'm going to show you real quickly here, these are cine loops of a patient swallowing. They're actually drinking the barium, and the barium is going down the back of the throat, and you can actually see this happen. So let's see if I can get the cine here. And that's actually the patient swallowing right there. And you can actually see them, they're actually choking. And as a matter of fact, it's exactly what they were that made them cough. So a little bit of the barium actually went down. It probably starting to go down into the lung a little bit. It got out of the, didn't go all the way down, or didn't go into the esophagus, and a little bit got in the trachea, and it caused them to choke. One of the things we look for is stroke patients that have had traumatic brain injury, things of that nature. Those types of things do happen, and that's one of the reasons we do certain types of tests to look and see how well you're swallowing, and if you're putting yourself at risk by swallowing. And that's when you would be under the care of a speech pathologist, and they would make recommendations to your provider about, what you could do to change your diet so these kinds of things that happen. A little choke every now and then doesn't hurt you, but if it's all the time, or every time you try to drink a glass of water, you feel like you're drowning, you definitely got a problem. So that's something you definitely want to bring up to your provider. The white stuff going down is actually the patient swallowing the barium. You can actually see that going down. The little horseshoe thing right there at the top, that's actually the patient's jaw, their chin. That's what you're seeing right there. And of course, you can see the ribs and so forth. And again, we look, what looks normal, what does not. Is there, deviation? Does the esophagus go way off to one side or the other, which could be an indication of a wholly different problem that's causing the swallowing? It has nothing to do with the esophagus. Something's growing, like a mass growing to it, pushing up against it. So there's lots of different things we would look at to determine what is right, what is wrong. Now for the next slide, this is everybody's favorite, the barium enema. Unfortunately, we don't do very many of these anymore. Typically, scopes have taken this over, colonoscopy. But we still do them occasionally, and there are different reasons why you might do them. As far as doing the whole bowel, which is predominantly what years ago what was only done, there are other things we look for now. You can develop a fistula. Women unfortunately get a thing where they get a rectovaginal fistula, or it'll be a connection from their rectum into their vaginal canal, and we'll do an enema for that and try to determine what's causing that. So that's one of the things we do look for, but also too, we look at the bowel as a whole. You can see the images A, B, and C are all the same patient. That's actually the enema tip going into the rectum, where that little tube is, and barium going up into the patient's bowel. In this particular image in C, you can see the patient's kidney. You can also see it a little bit in A. That's just coincidence. The patient probably had a CAT scan or something before, and they've had a little bit of IV contrast that's enhanced their kidney right there, and just so happens it visualized really, really well. But the other image you're looking at is actually for a barium enema. And then the big image on the right-hand side is actually a complete enema. That's actually going from the rectum all the way backwards through the descending colon up into the different parts of the large bowel, and that's what you're actually looking at right there. Now, cardiology is something that we all think about as we get older. We develop heart issues. Men think about it a lot, but it happens to women as well, and it can be something you just got to be aware of. Heart disease is very common in the United States. We don't eat right. We don't exercise like we're supposed to. And that just compiles any other issues that we might actually have. So the incidence of heart disease is pretty common. It's one of the leading causes of death in the United States. And there's different age groups have different leading causes of death, but overall, for everybody, it's one of the top ones in the United States, and probably globally as well, to be honest with you. It's relevant as we get older because the heart just doesn't work like it used to. And if you've abused it when you were young, too many cheeseburgers, well, there you go. There's a downstream effect. Unfortunately, if we'd all known we were going to live this long, we'd have taken better care of ourselves, right? So, well, imaging services that we offer at Lovelace as far as cardiac, and Lovelace as a whole, we actually offer cardiothoracic surgery, cardiac catheterization, nuclear stress testing, echo stress testing, echocardiograms. That's Lovelace in general. The Heart Hospital, Main Lovelace, Women's, Westside. We all have our little piece of the pie in that. There are certain things that are only done at the Heart Hospital, for instance, which would be the thoracic surgeries and the cardiac catheterizations, but nuclear stress testing and the echoes and stuff are pretty much done at all the sites. We do work with two big cardiology groups here in Bernalillo County, and New Mexico Heart, which encompasses Heart Hospital, Lovelace Main Campus, and Women's, and then Cardiac Care Consultants, which actually serves West Albuquerque and at our West Side campus. And it's actually two different groups, but they're all part of the Lovelace umbrella. And if you live on one side of the town or other, if you live over on the east side, you would be New Mexico Heart typically, but you don't have to see them. You can actually come to our side of town. That would be cool. But it's all patient preference. But if you don't want to drive across the river, you can stay on your side of town and you can do a consult with New Mexico Heart, and vice versa. If you're on the west side of Albuquerque or you're Rio Rancho, you can actually see the providers at Cardiac Care Consultants, and they would be very happy to see you. So anyway, just bear that in mind. Those are the phone numbers right there. So feel free to pause right here and write those phone numbers down. If you need to see a cardiologist, there you go. There's the keys to the kingdom for you right there. All right. In conclusion, we're going to talk about the big C. And no, we're not talking about cancer. That's what people typically think about as the big C. We're going to talk about the other big C. We're going to talk about COVID. Of course, we all know what that is. It's had such a tremendous impact on our society, our state, the world. It's still going on right now. Very fortunate in the United States, we've got it under control. Some countries like India and Brazil are still just, behind the 8 ball very badly. They just, of course, they have no healthcare infrastructure in those countries. And once something like that goes rampant in a country like that, it's just almost impossible to get it under control. It would be like, in some places they still have cholera outbreaks. So unfortunately, that's just a sad situation that they have to deal with. And hopefully they are able to get it under control. And hopefully the vaccines that we've actually been given out are actually insulate us from any of the variants that might come out, which so far they have. We've actually shown the efficacy, especially the Pfizer vaccine is actually really good. And Johnson & Johnson, although they did have the clotting issues, looks like it's going to be a good alternative, as is Moderna. So hopefully we'll continue to be very successful with our vaccine programs here in the United States and the first world in general, and be able to help out these other countries as well. A few things about COVID-19. It's called a novel coronavirus because it's new. It's not any other ulterior meaning like that. It's not number 19, as some people have said on the internet. Internet's your enemy. Don't believe what Facebook tells you. The 19 comes from the year 2019. Is when it was actually identified as a strain. And a lot of controversy, did it come from the bat? Did it come from the palanquin or penguin or whatever it was? Did it come from the Wuhan lab? Don't know. We're not getting into that here. All we know is it did originate from Wuhan, China. Which was controversial to say that for a long time. I have no idea why. Ebola came from, is called Ebola because of the Ebola River. German measles is called German measles because it originated in Germany. But anyway, the point is, it did originate in China and from Wuhan is what the suspicion is. Did make it over here into the rest of the world and currently dealing with the ramifications of it. CDC information is kind of old, to be honest with you. Some of the news bulletins and stuff update things. Some of it, the information you actually see online is actually a little older. A good example is about surface cleaning. Originally, we didn't know much about it. We were trying to figure out what was wrong, what it was, how dangerous it was. The concern was it survived forever outside the human body. We know that now not to be true. It dies very quickly without a human host. It can survive on surfaces, but very briefly. If you're using good hand sanitizing technique, if your surfaces are clean, normally you don't have to go in with a flamethrower to kill it. There's other diseases you almost do, C. diff being a good example, where you can only kill it with bleach. But COVID is actually easily killed. We are discovering, and it doesn't survive well on fabrics and things of that nature. So we're making a lot of headway in understanding what it is. Fortunately, and hopefully we'll continue to progress our knowledge. The big things are the masking, which has been a controversial topic. A lot of people don't understand masking. Masks do not protect you at all unless you're wearing an N95. And unless you know it's an N95, you know what an N95 is. You probably never don't have an N95. You got to be careful what you buy on the internet. If you know what an N95 is, they actually do protect you, but only if they've been fitted to you. They have to be fitted to you, and there's a process to that. You just don't buy it and put it on. So if you haven't done that, then you're wasting time and money. So the masking actually protects other people from you if you are ill. If you are vaccinated, the likelihood of you being infectious and spreading it are incredibly rare. It could happen. I mean, anything could happen. Aliens can invade tomorrow. I don't know. They might. You never know. But the likelihood of you infecting somebody if you've been fully vaccinated is incredibly unlikely. But people that are unvaccinated, or they're concerned about their health or the health care of their loved ones, you should not feel judged whether you do or do not. You have to do what's best for you as far as masking. And if you feel better wearing a mask, then by all means wear a mask. If you've been vaccinated, fully vaccinated, and you're not concerned, then you're right, you should do that. The big thing you have to remember, doesn't matter which way you go, wash your hands, cleaning, hand sanitizing, wash your hands, don't touch your face. If your hands are not clean, if you've touched things, you touch your face. If it got on there 10 seconds ago, you touch it and stick your finger in your mouth, well, guess what? You're probably going to get it under those circumstances. So hand sanitizing is very, very important. COVID-related imaging, one thing people say, can we take a picture of COVID? Well, yes, you can. We can actually see it, but it's actually not a very effective way to determine if a patient has COVID or not, because COVID pathology, or the way it presents itself, can actually look like anything. Now, once we know you got COVID and we take a picture of it, we can say, oh, there's COVID. But just to take a picture of it, it could be lots of different things, including really severe pneumonia. So imaging in and of itself is not always the best way to determine COVID. The tests are the best way to do it. And again, early stage imaging can be very problematic. If we do it too soon and we haven't done a test, we really don't know what we're looking at. You can make the assumption based on presentation, but there's lots of other disease processes, especially upper respiratory things, that it all mimics, just like the hemorrhage versus stroke. The symptoms mimic each other. Same thing for upper respiratory. If you're coughing up blood and you can't catch your breath, does that mean you have COVID? Maybe, maybe not. Could be something else entirely. So that's why we have the testing that we do, the swabs and so forth. So the image itself is a tool in the toolbox. It is not a be-all, end-all by any stretch of the imagination. Well, I want to thank you for your time, and remember, stay healthy. What's important is that you ask questions, you understand what you're dealing with. If you do have health issues, you want to be sure and, write things down, talk to your family, talk to your providers. If you think you do have a problem, say something. There's a reason why we have excellent health care in the United States. And that's why we're the gold standard. There's a lot of criticisms of how we deliver health care sometimes. But at the end of the day, it can't be all bad, because if the world looks to us, there's got to be a reason for that. Our physicians are excellently qualified across the board. We do get physicians around the world. A lot of them are very, very good, and we're happy to have them here. A lot of them have been trained in the English healthcare system, are coming out of India and Pakistan, which was set up by the English years ago. So they, and along with our homegrown physicians, are very, very good. We have a lot of excellent mid-levels now. That's becoming a growing thing in the United States, of mid-level care. So take advantage of your healthcare opportunities. Don't put off your healthcare. I mean, if you're healthy, you still need to get checked out. Once you hit a certain age, you got to kind of keep your finger on the pulse of things, so to speak. So thank you, and God bless you, and I hope you have a good day.